Hi, everyone. Welcome. My name is Kayla Magruder, and I'm an admissions counselor here at the Celia Scott Weatherhead School of Public Health and Tropical Medicine at Tulane University. And today I have Dr. Akilah Dulin, who is the chair of our Social Behavioral and Population Sciences Department. And today, for her Public Health Discovery Seminar series, she will be talking about engaging communities to advance public health. Hi, Dr. Dulin. Thank you so much for being here with us today. I will let you take it away.
Ac-
Before I take it away, really quickly, I just want to let everyone know that we will have a Q&A session at the very end of Dr. Doolin's presentation. So feel free if you have any questions about anything that she presents while we're still presenting, just drop them in the Q&A or in the chat, and we can address them at the very end. Now I'll let you take it away, Dr. Doolin.
Thank you, Kayla. Hi, everyone. I'm really happy to talk to you all as part of this Public Health Discovery Seminar series. And as Kayla mentioned, I'll talk with you all about how I've worked to engage communities to advance public health. But before I do, I'd like to mention that I have three primary areas of research. One is understanding multi-level resilience resources that under-resourced populations use to favorably manage their health. Two, I like to work to create resilience building interventions to help improve health outcomes instead of focusing on deficit or risk reduction models. And then third, I engage in extensive advocacy work to really remove structural barriers that require some communities really to find ways to be more resilient than others. Because what happens is resilience is a great area of research, wonderful topic area near and dear to my heart, but that requiring people to be more resilient constantly as they navigate these challenges really does tax one's health and their resources and reserves and could eventually be damaging to the person. And so I like to focus my areas of research on those three topics. So for this talk, I'll actually describe how we've worked to understand resilience resources and also engage in advocacy work. Initially, I was going to talk to you about this really cool resilience building intervention that we have, but I think the results are still too early to present, and so I will still talk to you about some work that I find particularly fascinating. The first one is that pertains to HIV. My colleagues and I at the time were really interested in collaborating. She brought a depth of expertise in epidemiology, and I have a strong social science background. And we really wanted to work in the topic of HIV, which was her expert area, specifically around African Americans, Black Americans living with the chronic disease. What we found from the existing literature is that the majority of work really focused on this risk reduction or what communities were doing wrong and really hadn't framed it in saying, okay, we know that there's a lot of risk behaviors, alcohol use, depression, anxiety, structural barriers like adverse neighborhood environments, structural racism. All of these challenges exist in everyone's day-to-day world. But that doesn't mean that everyone has poor outcomes. What are some resilience resources that African American or Black adults are using that helps them really overcome these challenges and favorably manage their health? We thought with this spin on the research question, we could work to shift paradigms instead of focusing solely on risk reduction, but also create real resilience building interventions that draw on existing strengths and take really an asset-based approach or empowerment model. And so we started to look in the literature to identify what does resilience look like among people living with HIV. And as part of this funded work, one of the first things that we did is we conducted a review of the existing literature to understand how resilience has really been defined in the context of HIV, what measures are being used, and what are some of the research gaps that we identified. Specifically, we found first that most of the work did not take a sociological approach, meaning when researchers described the construct of resilience or people's ability to overcome challenges and favorably manage their health, they were focused on what that individual was doing. How were they coping? What were their personality disposition characteristics that helped them overcome the challenges? But we know that resilience exists and it's external to the individual. It operates in their living spaces, the people with whom they interact, the neighborhoods, the organizations, and the policies. So there's more to resilience than just what an individual brings to the table innate to themselves. Second, what we found as a gap in the literature is that the majority of the resilience research in the context of HIV used these general measures that weren't specific to the lived experience of HIV or chronic disease. These were measures that could be applied across different settings as they were general coping measures. But what we do know from the very, very rich qualitative literature that people's resilience resources are more unique than what's being captured in the current literature. And so we were left with the idea of really needing to develop this measure, especially in the context of working with people and helping those with lived experience and working with them so that people with lived experience contributed to the research. Because often these measures were developed by researchers and they were absent input from the context of people who are directly impacted by living with HIV and the resilience resources. So we aim to really address these gaps, and we wanted to use a mixed methods approach. So that means using both qualitative and quantitative approaches to integrating those two to really identify what multi-level resilience resources exist among African American or Black adults living with HIV who actually demonstrate progression through the stages of the HIV care continuum. And for us, that meant community African Americans who were able to attend at least 75% of their scheduled clinic appointments, and they did not have more than 2 consecutive detectable HIV-1 viral load measurements. So we were really working with the population who already demonstrated resilience to ask, what are they doing that helps them overcome these life challenges to favorably manage their health? We use this approach known as concept mapping, which includes 6 steps. So you'll see the first step as preparation, where we actually develop the focus prompt or the questions that we use to generate ideas from research participants. So the out of the 6 steps that we conducted, 2 of those steps involve direct data collection with participants, including steps 2 and 3. And step 4 and 5, where we analyzed and interpreted the data, that's where we looked at the concept maps and conducted additional analyses. And finally, at step 6 is how we use the results from the concept mapping, and I'll talk about each of those steps, but I'll only highlight briefly steps 4 and 5. So for step 1, our team, we created these 3 sub-focus prompts, all related to the construct of resilience within the context of a socio-ecological model. So we asked about individual level resources, interpersonal resources, so those from family, friends, and other loved ones. And we also asked about neighborhood level resources that help people what they utilize to address these ongoing challenges so that they're able to stick to their HIV care. And when we defined HIV care, we talked about going to their scheduled clinic appointments and taking their HIV medications as prescribed. So you'll notice we asked those 3 sub questions, all under the overarching theme of resilience. We made sure that the questions were appropriately worded for the audience, and we iterated on those quite a bit because the focus prompts really do inform the rest of the project. And if those are not well designed, then you don't have good data or usable data at the end of the project. So we took our 3 focus prompts and then we conducted what we call these generating ideas sessions with the study participants. We use what's known as a modified nominal group technique. We held 5 group sessions and 11 one-on-one interviews based on the preferences of participants. And again, we invited people who were doing incredibly well in managing their HIV to participate in these sessions. So during this step, like I mentioned, we use this modified nominal group technique that basically is a round robin process where each participant gives one statement in response to the focus prompt until all ideas are exhausted. And so we did this across 2 different sites. Participants generated 365 statements, which is quite a lot. And we couldn't use them all, of course, in the analyses, but we use this multi-stage data reduction process that involve relying on reviewing, editing, refining, and reducing the statement set using in part what's known as a content validity index. So that's where we have our experts in the concept of resilience review the items to make sure that they are actually reflecting that construct itself using a structured process. And we also pulled some items from existing measures from the literature that may not have been mentioned during our generating idea sessions to refine the entire item set down to 95 statements that we used in step 3. And there, with participants, 42 of them, they engaged in what's known as this unstructured sorting and rating process. We conducted 6 group sessions and 18 one-on-one sessions. Even though participants met in a group, this actually task is performed individually. So participants, we hand each of them a stack of cards, each with one statement on each card, so they get 95 of them. We ask them to read these very short statements and group them into themes or categories that they think are similar. And after they've done that, then we ask them to rate the statements based on their importance, how important that statement is for resilience, and then we also ask them to rate it on feasibility of it being something that can be changed, meaning can we incorporate this statement into a resilience building intervention in the future. Out of the total number of participants who engaged in the process throughout, the median age was 53. All of them, as you can see, were virally suppressed. Almost three-fourths were stably housed, which we found really important because that means that 27% were unstably housed, but we're still, in spite of that significant challenge, as we know housing is a really important social determinant of health, they were still able to be connected and engaged in HIV care and its management. Uh, 56% were male, and most of them lived in neighborhoods that were 3 times as disadvantaged in the average US Census tract, meaning they lived in riskier neighborhood environments that maybe were high, that not maybe, but they were higher crime and less safe relative to other communities in the US. We use concept mapping to analyze the data. And as I mentioned before, I won't get into the nitty gritty of that. But basically, what happens is all of the data are used and represented as these visual maps depicting the relationships between each of the statements and how they're grouped or clustered together. So based on the analyses that we did, there were 12 different clusters. We assigned a label to the cluster to represent the theme of the statements that were sorted within each cluster. And I'll show you some of those examples as we interpret the data. This is us as we actually met during our first retreat to plan actually how we were going to carry out the work. So these are some examples of the clusters and the example statements or ideas that emerged. So we grouped them by the sociological model. So you can see some pertaining to neighborhood, interpersonal, and individual level. And interestingly, even though we did not ask about the organizational level of a sociological model, themes still emerged there that were critically important. So at the neighborhood level, they talked about neighborhood orders, such as living in safe neighborhood environments, no drugs or alcohol, and safe housing as resilience resources that they were able to use to favorably manage their health. They talked about having emotional support, having a strong support system, people praying for them. At the individual level, there's really the strong theme that emerged about self-care and compassion, having self-confidence, having strong faith and belief in God, and also accepting that they're living with HIV. At the organizational level, they really talked about the environment and really how staff can set the tone. So they talked about kindness and compassion and positive feedback that they received that helped them engage in care. And of course, the resilience resources that are also important is having, programs that help pay for HIV medications. Additional cluster examples that emerged were neighborhood social services, instrumental or informational support, patient activation, and then around medical care, and then patient activation around health behaviors. So at the neighborhood level, social services such as having social support services, being able to get connected to bus transportation services, and having church services in the neighborhood were facilitative of care. At the interpersonal level, having people in their lives who they could go to ask for help and who provided them with a sense of love and caring were really important. And in the context of medical care, really having communication, good communication, that's important, the communication type with a doctor, being able to routinize their adherence, and also being able to ask their physician and people in the clinic about any research breakthroughs so that they're actively engaged in the current state of the science. They also talked about health behaviors that were facilitative of care, including being determined to outlive HIV, making sure that they keep the medications with them at all times, and really having a strong sense of self-discipline. So what we were able to conclude from this work is one, is that, resilience resources really do exist at multiple levels. right, we found that the overwhelming majority of the resilience resources that we mentioned were generated by study participants. I think we included maybe 16 of those from the existing literature, and the others were generated by participants. Resilience exists at the individual level, interpersonal, organizational, and neighborhood levels, and likely at the policy levels too, as some of our participants did mention the importance of Ryan White. So we really should be thinking about a more holistic view of resilience and not just at the individual level as being innate characteristics. The second thing that we learned is that there are resilience resources specific to living with HIV, and that we should be using these measures, the chronic disease specific measures, in the specific context in which we're doing the research. So it's not enough to use just these general measures, but we really need to understand those specific resilience resources specific to living with HIV. And the third thing that we learned is that the resilience resources actually cut across demographics and neighborhoods. I didn't show you these data, but we rated the relative, as I mentioned before, participants rated the relative importance of those resilience resources, and they were very strong. The same ones were rated as strongly between men and women, and also across those who were housed stably or who were stably unhoused, as well as those who were living in higher risk neighborhood environments versus less risky neighborhood environments. If you are interested in learning more about that particular study, it is published and available in AIDS and Behavior. So after we completed the concept mapping study, we really wanted to think about how we could utilize those data. And we've been really intentional about doing several things. The first aspect of utilization that we wanted to do is to disseminate the findings back to the community members because they were really really active in engaging and developing the research, and it's really important that we communicate it back to them in an accessible way. So we wanted to create a lay audience animated video of the results. Then we thought, we could really address an existing gap in the literature by creating a multi-level resilience measure. So we use the concept mapping data to create a measure using extensive psychometric testing analyses. Third, we then wanted to find out whether, these resilience and non-resilience factors are prospectively associated with HIV management in the context of neighborhood risk environments in which people were living. So the first thing that we did is we created this animated video that I will not play for time. It is available on Vimeo, and we disseminated it back to our community members through the clinic partners with whom we conducted the research. We also were intentional about identifying different community organizations specific to HIV and we sent them targeted emails with the Vimeo link if they were interested in understanding these, resilience resource processes that participants generated as part of our study. So we disseminated this widely, and it played in our clinic's site waiting rooms, actually, which was really nice. So after we completed the animated video, the next thing that we did, as I mentioned before, is we were really keen on developing this multi-level resilience measure that could be widely used. And for us, it was critically important to make sure that the measure is widely accessible and freely available and available. So this measure is actually published along with this study in the supplementary materials, and it is open source use. I think that's the word. And we have the detailed descriptions of the items for the short and the long form, how they should be used, how they should be interpreted, and how you handle missingness. So once we got that published, we described the steps that we use to actually develop the measure, because oftentimes we see a lot of people will develop measures, but they haven't necessarily undergone this extensive, rigorous psychometric testing that is needed to make sure that your measure is both valid and reliable. So we conducted these 4 steps, right? So I talked a lot about how we generated the item content through the concept mapping, and I mentioned that we also reviewed theories and measures of resilience. So that's how we generated the item content. Secondly, we developed the draft of the measure through the at reviewing and editing phase that I've mentioned before, as far as the content validity index, and then the additional steps that we completed during the concept mapping process with study participants. The third component that we did to ensure that the measure was valid and reliable is that we conducted cognitive interviews. And that basically means that we work with 20 adults We use verbal probing to assess their understanding of the different concepts that we included in the item set, to assess item clarity and determine um, the appropriate ordering. We also completed what's known as behavioral coding to assess if people's nonverbal cues indicated that they were having trouble with understanding the item set. So we took those after we completed those cognitive interviews with the first 20. We took that information, we revised the measure, and then we completed a second round of interviews to make sure that the measure was understood in the way that we intended to deliver it. After we did that, our fabulous psychometrician, Dr. Joe Fava, completed both exploratory and confirmatory analyses, measurement and variance, criterion validity assessments, Cronbach alphas to ensure that we had again, like a valid and reliable measure. And that's available in AIDS behavior. It was published in 2022. And then we have taken that measure to and done work to determine whether what is the relationship between the multi-level resilience resource actually and clinic adherence and virologic suppression among African Americans living with HIV in the South. So we published two papers from that quantitative finding so far, and they've demonstrated that we found like modest positive associations between higher multi-level resilience resource endorsement and virologic suppression. We didn't find that relationship changed based on the type of neighborhood environment in which the participant lived. The second study findings, which are in press, we found that those who had stronger endorsement or greater endorsement on the multi-level resilience resources were more likely to be adherent to their clinic attendance. So that was quantified as more than 87.5% of their scheduled HIV primary care appointments over 12 months. And that distinction is important because these are people who attended as scheduled, not those who canceled and then attended later. We are continuing to do some work in this area and doing some additional analyses, but that really wraps up this part of the topic area on HIV and resilience. We couldn't have done this work without the generous funding of NIH. 100% of it was covered by them. And of course, we thank our study participants, clinic staff, and investigative team for their important contributions to the work. And third, our research team. As I mentioned before, we're continuing to do some novel analyses. This work happened during COVID, so we're really thinking about what we want to do next and how we make those adjustments, considering the context of the COVID environment. And also, we want to think about, so we work primarily with a clinic sample, but we want to think about how this measure actually functions in a community cohort of people living with HIV. So that's probably the next step. And also, we want to think about potential resilience building interventions that we can leverage from the concept mapping data. As I mentioned before, I was going to talk to you about two areas of research. Well, the first one is research. The second is using my research skills to engage in advocacy. So that's a little bit different twist. As I talk to you about these particular projects, those were peer reviewed in the peer review published literature, and they were community facing. The work that I'm going to talk about now is overwhelmingly community facing. And as I mentioned to you, doing the work in resilience is really rewarding, but there's this issue of all these structural barriers that require some communities to be more resilient than others. And I really find a large part of my passion and my purpose in using my skill set to advance equity in the context of removing structural barriers. So we had the opportunity to be funded by the United Way, which is a foundation. So this is not traditional research. We My community collaborator and I, with whom I've worked for many, many years in Rhode Island, we created this State of Black Rhode Island initiative, which is conducting specifically policy research for the prosperity of Rhode Island's Black communities. So I want to get this disclaimer out of the way. At the time, this research was funded by United Way. The views, of course, expressed here do not necessarily reflect the views of the United Way of Rhode Island. But this was the epitome. For me, is the epitome of community engagement and community collaboration. We have a community PI who works on the study with me with the same standing. And I don't like calling it a study because it's not. It's ongoing. It's an initiative. We have a community advisory board that is filled with movers and shakers in Rhode Island in their own right who are really working to advance well-being of Black communities in Rhode Island locally. And so everyone on here is a community advisory board member except for Caitlin Starks, who was a student at the time. And then Kobe Dennis is our community partner. Melina Yago was also a student at the time. And the remainder of the folks who are presented on this slide are community advisory board members. So when we got the work funded, we were really dedicated to doing several things. The first is that we saw a lot of data about Black Rhode Islanders without context, right? So you would see, oh, there's a disparity here, there's a disparity in health, there's a disparity in this. But the data were never contextualized from a historic and current context that really describes why we're seeing those same outcomes. I think it's really dangerous to present data without context because it allows people to fill in the blanks. And I don't think we're not presenting the whole picture when we just present data without context. Second, we really wanted to hear from Black Rhode Islanders what their perspectives were, and what topics they identified as being critically important. And third, which is actually a little bit out of order, is that we really wanted to have a very strong community advisory board with a presence to help guide and shape the work. When we had our first meeting, we talked about what our goals were, what we wanted to accomplish, and everyone was on board with the work that we're doing, but also wanted to talk a lot about what kinds of work should we be doing? They just identified that we should conduct some secondary reviews. So look at the existing literature, put together some community facing reports with specific policy recommendations that are tailored to legislators who can affect change. So the first thing that we did is we generated a home ownership report. And I'm very proud of this report and the many things that we've done together. So we've been working collaboratively since 2020. We only went on a 1-year hiatus when I made the transition to Tulane, but we have restarted our work and we are getting ready to release an update to our home ownership report shortly. So this was the first report that we ever generated, and this is the actual report. We were very strategic in that we wanted to present the home ownership rates. We wanted to contextualize the home ownership rates in the report for Black Rhode Islanders by providing the historic and current barriers. Our community advisory board members and our funders were really on board and encouraging us to include policy recommendations. So not just talking about what the problems were, but providing some potential solutions. And then we were very intentional about engaging communities in meaningful ways to respond to the report and also to engage in action. So I will skip all of the barriers and because I know all of you know that, but it's also accessible in the report. And I'll jump right to our policy recommendations that we created. One of the first policy recommendations, not the first, the set to increase Black home ownership really focused on financing programs. We wanted to engage in targeted outreach, excuse me, and also sustain homeownership. So we proposed to increase access to mortgage lending for those with specific credit scores or higher because there is racism in lending and credit scores, even how they're determined. We proposed that there be small dollar mortgage assistance in education and targeted lending in Black neighborhoods specifically due to the histories of redlining and disparities in opportunity and access. It's not enough to have a program. You have to engage in some targeted outreach. So you can create it, but you also have to be very intentional in increasing awareness and visibility and access to the programs for the communities with whom you're trying to work, and also to address their perceived barriers to home ownership. So even though you have the programs, there may be some gaps between what participants believe is being helpful and what might be challenges that also need to be addressed to help them engage more in increasing home ownership. And when you get people in houses, you also have to find a way to help sustain home ownership. A lot of Black communities were impacted by foreclosures due to those adjustable rate mortgages and structural racism in housing, frankly, and neighborhoods being undervalued. So we thought that there should be some focus on foreclosure prevention programs to help stabilize neighborhoods, increase access to refinancing, and also expand first-time homebuyer programs. Our additional recommendations were that, again, of course, understanding the barriers and facilitators from the perspective of the population with whom you're trying to help, making sure that the outreach strategies are targeted but also tailored to the specific audience. The homeownership program should be customized, and then to make sure that they're being implemented as intended, that we really should conduct assessments and track outcomes. And we also need to advance policy advocacy to really create structural change. So, we talked a lot about the barriers and the challenges, but we were very intentional about creating a very targeted, focused policy recommendation section that was backed by the current state of the science. We were very, very intentional about making sure that our reports had wide reach. We met with policymakers and community organizations. There were a number of community events, and I'd like to say that some of those community events were launched by the communities themselves. They took our report, and based on our report, they mobilized an action and had a large number of community homeowner education events for Black communities specifically based on our report. And we also talked with our Municipal Reparations Committee. We participated in United Way Forum and a number of other legislative events. We took our report and we sent probably 80 emails to legislators, community organizations, targeted emails to get this to the forefront. And we really had a lot of success doing that community focused work with this homeownership report. So we had a number of news articles actually picked up our report. It was featured in the Boston Globe, the Providence News Journal, um, Uprise Rhode Island, and a number of other news organizations carried our work. We held a number of town halls. We had a community town hall specifically with a panel who discussed the report, but also reacted to the report and talked about other ways that we can create and increase homeownership for Black Rhode Islanders. Like I said, we participated in a number of community events and presentations. We talked extensively with our housing network in Rhode Island as well. Our Municipal Reparations Committee, who was advising the mayor on how to use the funds, the ARPA funds, recommended specifically homeownership and financial literacy programs based on our report itself. And happy to say, I mean, this is a double-edged sword because road redlining still exists in Rhode Island, and the U.S. Department of Justice secured a $9 million agreement with Washington Trust due to redlining in Rhode Island communities last year. And as part of their press release announcements, they cited our work. So you never know who's looking at your work. You never know how it's going to be leveraged. But when you put it out there, um, it can be used to advocate for change. So that was exciting. Our second report that we created was about criminal justice or injustice in Rhode Island and its disparate impact on Black Rhode Island communities. We talked about the incarceration rates and again presented the historic and current context of incarceration. We presented these, important policy recommendations, and we followed the same blueprint. There's also that community response and action component that we also tied to the work. So we recommended several things: that the legislature commit to passing racial equity-oriented legislation, specifically that they focus on reducing the Black-white disparity in incarceration to Rhode Island so that it matches the national rate by 2025. So the Black-white racial disparity in incarceration in Rhode Island is much higher than the national average. We thought it was important for them to fund a commission of formerly incarcerated Black people to provide legislation insights. We are really advocating for this passing of this racial equity impact assessments and criminal justice legislation so that any legislation that's introduced, you do a racial equity impact assessment to determine, are communities being disproportionately negatively impacted? Are they going to disproportionately, benefit? Who will this harm? Who will this help and how? And we recommended that that be applied to existing and potential legislation, that findings are publicly reported and allowing for public comment, and that any mitigations be retroactively applied to Black Rhode Islanders who've been harmed by this legislation. We also presented extensive evidence about the benefits of bail reform and that pretrial supervised release might actually be a better option. And we suggested a commission to study, to determine the impact of bail reforms on Black Rhode Islanders and the economic benefits, the potential for the economic benefits for the state as a whole. And last, we talked about the Committee on Racial and Ethnic Fairness in the Rhode Island courts, which was an initiative that had been launched after George Floyd to really do some deep reflection and seeing how the impact of the court has potentially harmed Black Americans. So we encourage the committee, to apply racial equity assessments to their policies. and to make these assessments publicly available. Because again, they talked about some of the things that they did well, but they didn't have a racial equity component to it. So this report also had a pretty great impact. It was published again in the Providence Journal. There was legislation that was introduced based specifically on our report. So this Racial Impact Assessment Act was introduced by these several senators, again based on our work and we were really intentional with collaborating with local community organizations that really helped advance this work. So when this was introduced, we actually I went and was able to testify of the in support of the legislation. As you can see, I presented not speaking on the behalf of the university. We can engage in advocacy on our own personal time and really talked about the impact and the benefits of this kind of legislation. And then last year, we were invited by the Supreme Court of Rhode Island to present our criminal justice report and our recommendations to them directly. And so I went to Rhode Island early last year with one of our community partners, Wayne and Nelson Davies, and presented the work. So I just wanted to give you a flavor of some of the things that we do. The work, like I mentioned, is ongoing. We're releasing an update to the homeownership report, and we are planning to launch that full scale again. So I want to thank you for your time. I think I'm right at 37 minutes, so 3 minutes early. I welcome any questions and any questions that you may have.
Thank you so much, Dr. Dulin, for your presentation. That was great. We do have two questions. I'll start with the first. This question was asked at the very beginning of your presentation around your HIV research. What made you want to focus on this research?
On HIV specifically. So my colleague and I were both early career faculty. We knew we wanted to work together. I have the expertise in social determinants and cardiovascular health. She has the expertise in epi methods and HIV. And we said we want to do resilience work. We will do one leveraging her expertise in HIV, and the second will leverage my expertise in cardiovascular health. We got both funded. The HIV project was first, and it was primary data collection, which I was much more enthusiastic about because that's what I do. She was enthusiastic about the cardiovascular health because that's secondary data analyses, which is her strong skill set.
Thank you for that, Dr. Dulin. As we're going through these questions, if anybody has any, please feel free, drop them in the Q&A. You can also drop them in the chat. I just want to make that announcement again for those of you who joined us after the initial announcements in the beginning. Now, Dr. Doolin, the next question says, I appreciate the crucial work and efforts being made to dismantle the structural barriers faced by marginalized populations living with HIV. This topic fascinates me as I am particularly interested in addressing the social and structural vulnerabilities of people who use drugs while also recognizing the importance of resilience in their reintegration into society. I would like to know your thoughts on how the methods you employed to tackle these compounding vulnerabilities in marginalized populations might be applied to measure the resilience of individuals who use drugs in terms of their reintegration.
I think that's a fantastic topic. I will say I'm not as engaged in that work just yet. It's near and dear to my heart for personal reasons, given I'm from Ohio. You can use the concept mapping methods and you can do the exact same thing that we did as long as your focus prompts are, worded appropriately for the audience and for your intended outcomes, you can do the exact same thing. And in fact, I would encourage it.
Thank you for
And
that, Dr. Doolin.
I will say, I'm sorry, that the steps that we talked about, I highlighted, I summarized them briefly, but those steps are detailed in the content mapping resilience paper. And you can, if you're interested, you can take a look and you can take the existing questions that we created and modify it for your context.
All right, we do have another question. Do you have any recommendations for how community members can get introductory or entry-level involvement with work addressing social determinants of health?
It's funny because I think they're already, just by the very nature, community organizations are already doing social determinants of health work. So that's one way to go about it. The second way is if you, reach out to faculty members who are doing this work and connect with them directly or send them an email. You never know if they're not able to support you, they may connect you with someone who is.
Thank you.
You're welcome.
Next question. What is the main objective, and what were some of the challenges encountered achieving this objective?
The objective for which project specifically?
If the individual who asked that question could drop a little bit more context for which objectives. We also invite any other questions at this time to also be added to the Q&A.
So I would say, I mean, I'll talk about both of them. The first, the study with HIV, there's always the main objective was to create and test the multi-level resilience measure and examine its associations with HIV outcomes. The challenges encountered are always recruitment can be slow, and that can be a stressful process trying to meet your recruitment numbers. The second challenge we encountered was COVID. Otherwise, we were a really well-oiled machine because we had a strong plan at the outset, and we were very intentional about how we would implement the work in phases. The second project, the main objective is to, our little tagline is advancing the prosperity and well-being of Black Rhode Island communities. That's the main objective of our State of Black Rhode Island work. And we've not encountered any challenges. We've received overwhelming support from community. Wait, actually, we have, because the third aim I didn't mention was the photo voice. We want to hear about the perspectives of experiences and challenges and the beauties of living as a young Black adult in Rhode Island. And we have thus far been unable. We've had difficulties recruiting, so we're going to try again very soon.
That was perfect. Thank you, Dr. Dulin.
You're welcome.
Do we have any additional questions at this time? Oh, we have a comment in the chat. Thank you very much.
Thank you.
All right. Well, if we don't have any further questions, comments, or concerns, oh, and Dr. Dulin just dropped her email in the chat in case anybody wants to connect to further discuss any of the research that she has presented here today. Please, please, please email her. You can also email our office if you do not take Dr. Dulin's information now. Oh, we do have a question. Can you share any links to follow your work?
We are working on we don't have a website yet. And so unfortunately, I can't share a link. I can only share probably a link for I don't have any. I'm sorry. I don't have any, but we'll work on getting a website. Sorry about that.
So not yet, but stay tuned.
Right.
Stay tuned. I see that one of our panelists has a hand up. Would you like to drop a question or comment in the chat or the Q&A? And for those who want to stay tuned with Dr. Dulin's work, all of our faculty, including Dr. Dulin, do have faculty bios on our website. On every single departmental page, we have 7 departments here at Celia Scott Weatherhead School of Public Health. And Dr. Dulin is the chair of the Social Behavioral Population Sciences Department. Susanna Chase actually just dropped her link in the chat to her faculty bio. You can follow along with a lot of their research there. If they do any seminars, they have any, current information, classes teaching, different things like that, you'll be able to find all of that information there. All right, we got some more thank yous. Thank you, everyone. If we don't have any further questions, I will let you have the last 15 minutes of your hour back. Thank you so much, Dr. Dulin. This has been great. Thank you so much for taking the time to present your research.
I'm happy to do it. I enjoyed myself. Thank you for the invitation.
Of course. Have a great day, everyone.
Bye, everyone.